Nick Macchione has come out from San Diego to be with us today, and we're super excited that he's here. So let's give him a round of applause and welcome him to the stage. Nick Macchione from San Diego County. So we're going to get into a lot of stuff, and I should note that Nick brought a slide deck, and he had a lot of prepared remarks, and then we got talking last night, and he said, well, let's just roll with it, just see where it goes. So that's what we're going to do. So let me start with an easy softball, Nick, and say, from where you sit, San Diego County, county of 3.5 million people, and as a public sector servant, what are you keeping your eyes on when it comes to this sort of interface between the private market and the public sector, both at the state and local, but also federal level? What are the kinds of things that you're watching in San Diego County that may be analogous to what's happening here in Hawaii?
Thank you. Good morning and aloha. And from where I sit, first let me address the beautiful people in the audience, because you mentioned something of comparison between San Diego and Hawaii. And everyone thinks it's the weather, it's the great military, it's the people. And let me build on that. So where I spend my time is how do we get adults to get along from all levels of government? And I think there's a little pun in that, because obviously we know what's happening with federalism, and particularly for states like Hawaii and California, and working with the federal administration, there's some major challenges going on right now. But in the course of those challenges, we still have to find ways of working together and serving our community. Being local government, I describe it as we're kind of the retail. And with all respect, and I have immense respect for our state health department, for California, a lot of that is kind of this, if you will, distribution center of resources from Fed and developed by state to local. And obviously, you have wholesale from the federal government. These layers of government and harmonizing these layers, how we, with a lot of noise going on, and we'll touch about that, the amount of noise going on in the public policy space. But in the context of people's lives, the social contract, and I really loved how you framed that. For us, is how we're building those relationships. In San Diego, we don't build walls, we build bridges and relationships. We do that south of us with Mexico, we do that across our cities. And this whole idea about moving from this kind of collaborative cross-sector work stems not just locally, but also with our federal and state partners. So it's that strategic alignment on, can we focus on certain things that matter, that can lead to better outcomes? And we'll touch upon some of those examples.
So you mentioned the wall, a structure, steel slats or otherwise, and let me just sort of jump in on the politics of health policy and tee that up with California's long been a blue state for, you got to your position in 99, is that right?
In 97.
97. San Diego County, however, has generally speaking been pretty red, not bright red, but right of center, certainly. How have you found success in health policy given those cross currents of a state politics and a local politics, which are different regardless of what happens at the federal level?
Yeah. As kids, we know, remember, as kids, we learned we blend colors. So that's what we had to do here. So we created purple, I think. The reality is, we have been in San Diego, in some parts of the Southern California, Orange County, and other neighboring counties, more conservative. That has been changing. The geopolitics is much more now, I would say, even keel between the agendas. But with a conservative board, and we just had a change in our board with having a Democratic representative, we've been able to focus on less the politics and more of the issues. And what do I mean by that? You may have been watching what's happening with the asylum seeking. This is the South Americans who are seeking escape from violence, coming up through spending a month and traveling up through Mexico, and have been held in Mexico waiting to get in legally into this country, asylum seeking. The federal government, upon letting them in, basically puts a tracking bracelet on their ankles and then gives them a court date wherever they end up in the country with no other resource. We as a county government actually moved forward in providing public health screening assessments, working with our nonprofit organizations. Point is, we were the adults in the room taking care of families with children in need and welcoming them and making sure that they were stable enough as they moved on to their journey in their host community. That's an example about how we focused on the issue of women and children and parents in need and less on, well, that's a federal issue, or these are folks that are not legal residents and so forth. So how we frame the conversation about the needs of people helps, I think, get through some of the conservative, and by the way, in that we had to take a public vote. Mm-hmm. And the conservatives supported that because it was good public health practice for the region as well as helping families.
So how do you, I think I'll answer my own question here, which is personal leadership. But your personal leadership aside, how would you counsel folks to navigate these cross currents? There isn't that same kind of cross current in terms of the party divide in Hawaii, other than the federal and the state currently. But navigating cross currents of politics in a very challenging partisan time, it feels like you are in front of your policymakers, bringing them along, but I know you're never too far in front because you got 5 supervisors that'll fix you just right if you're not careful, right? So how do you sort of counsel folks to kind of manage the pull to lead policymakers without getting too far on your surfboard, so to speak?
Well, to my board members maybe watching, I espouse the policies of the board. Let's start there. You know what I mean. But to DJ's point about as an executive, my role is to provide the data. And it's to cut to the noise, and the example for the asylum seeking, doing nothing was an option. Punting and saying that is a federal responsibility. The state did come to some help, but doing nothing was an option. And however, there was a consequence of that. We had presenting families with chickenpox. Many of these children were not vaccinated in Guatemala, for example, from their host community, country. So from a public health perspective about protecting the public's health, it was important to serve these families to protect the county region, because if not, we've experienced things with outbreaks like hepatitis A and other things that if you take no action or soon enough in terms of prevention, you will create a more costlier situation for the region. Mm-hmm. And so how you frame that issue of doing, for us in the field, it's about, helping families that are struggling, that have experienced immense trauma on the way up here, and physical ailments, and stigmatization and so forth, and going to helping serve those. But for others that take maybe a different view, it's, well, there's a cost implications if we don't. Mm-hmm. So it's always looking at that multidimensional to bring as much of the majority collective to be supportive of those policies.
So I mentioned about 3.5 million folks that reside in San Diego. Talked a little bit about the community, but tell us about the government. Tell us about your department, number of employees, give or take, the scope of the services that you procure, provide. Give us a little rundown.
Well, we have a big Italian family. We call Health and Human Services. In 1997, it's interesting, we're in the bookends between welfare reform and health reform. So in 1996, President Bill Clinton passed welfare reform, temporary aid for needy families. And that's very important because that set the tone for San Diego that in 1994-95 was at the brink of bankruptcy. And Orange County, just north of us, did declare bankruptcy. I don't know if people realize that, like Detroit. So San Diego was pretty close behind. They took a really transformative perspective of, wait a minute, they didn't want to go down that path. So they looked at every aspect of what county government was doing. And I wasn't there in 1996, I came in 97. One of the things they talked about was, well, could we do a better job with the local spend of helping people get on self-sufficiency? It was really to manage costs, but in the other respect, in the Republican kind of conservatives, it was, smaller government, Can we create smaller government, have people become more self-sufficient, not relying on government? So they took 6 separate departments, your mental health, your public health, your Medicaid, your child welfare, aging, veterans, all these different departments, and created this super agency. And I was there when we first created it, so I've been there since the inception. Today, and along the way, several years ago, we actually then integrated public housing, because housing is health. We saw that, and that was something we framed. So we oversee public health, Medicaid, all the entitlement programs, public housing, child welfare, and adult protection, and a whole array of other services. We're 6,400 employees, about $2.2 billion annually in what we serve. We believe, very importantly, that there are things that the community can do best, particularly neighborhood-based. So we believe in the public-private partnership, so we do have contracts. Fair amount of our behavioral health contracts are contracted out. So we have about 350 community-based organizations and a few for-profits that we contract with for about $600 million of that $2.2 billion.
Wow.
We serve 1.3 million San Diegans unduplicated. Now, the public health folks in the audience would say, wait a minute, you serve the entire region. That is correct. But in terms of direct services, the 80,000 people who are seriously mentally ill in our drug treatment programs, the 3,500 children in child welfare, the number of folks, the over 900,000 Medicaid lives that we render to, our psychiatric hospital. When you look at all the people unduplicated, it's 1.3 million. So that's a big responsibility, a little bit of more than a third of the population. And our mission is really simple, is how do we help them live better than how the condition we found them? Mm-hmm. So how do we improve that building the human capacity of people and communities by which they live so they can then be sustained and their well-being.
So we host this event in San Diego as well because you told us we had to.
Thank you.
In fact, we hosted it in Los Angeles in 2015, Southern California Sierra Forum Health Policy Conference, and you said, LA is not Southern California. San Diego is Southern California.
LA is the state of LA, but there's other of us that live.
The country of LA. And we feel really great about our attendance. And then you have a party and you get like 1,200 people that show up. So every year you have this event. It's part of your Live Well San Diego initiative. Tell us what that initiative is. Tell us what it's doing and sort of the vision.
So in 2008, we saw what was happening with the debates between McCain and Obama. And what we knew, and that leading up to that presidential debate, and the campaign, was that there was going to be health reform. We knew that. We knew there was going to be clearly coverage reform, payment reform, but there was going to be the third, delivery reform. And the delivery reform is left to us, right? To the states and localities to do. So I took the job as the director. I was a deputy prior to that. So in 2008, when I became the director, the importance of thinking about what we can do in our region. We were doing fairly well as a county health status, kind of the middle of the road. But we said, what can we do? What can we do to get further out from where we were ranking in terms of our heart disease and our obesity and asthma? And we took a hard look in the mirror, and we said, can we harbor together the might of all the human services capital we have with our public health, with our community partners, and can we take a different approach? And what we were really talking about, not thinking about it the way you framed it very eloquently in the opening, was our social contract. Was that it wasn't just the job we were doing, we were clearly executing on our individual fidelity to our professions. The issue is the fidelity to what our hospitals were doing, to what mental health was doing in child welfare and housing and case management and aging. We said, can we take the fidelity of all these wonderful islands and silos of excellence, and can we have a fidelity for a single cause? Could we be audacious and say, can we have a fidelity of having everyone in San Diego living well? To say, well, what does that mean? And we focused on wellness, well-being, because we didn't want the polarizing terms, welfare reform or Obamacare, and we're very big supporters of, obviously, Medicaid coverage and expansion. But we didn't want polarizing because we wanted to bring both the conservatives, the liberals, and everyone in between on a common inclusive vision. And that vision was helping all San Diegans live well. In that journey that we started, focused first on health, was this idea about how do we focus on chronic health conditions. And we focused primarily on cancer, heart disease, diabetes, and asthma. But the journey for wellness was defined with not just, and I'll say this with all due respect, on healthcare, public health, population health. Because in the presence of violence, you can't achieve health. And my upbringing in Newark, New Jersey, and working with the inner cities in New Jersey showed when people are fearful to get their immunization shot, they're not going to get their immunization shot. So we did something quite audacious and said, we're going to do safety reform. We're going to take a dyad approach between health and safety reform. And then said, and wrapping around that is that place matters. That we needed to have the adequacy in the natural and built environment, which we call thriving. So this three-legged stool, if you will, of health, safety, and thriving created for us, not our initiative, but our game book that eventually became adopted by our county government. We're $6 billion annually. That is our budget, that is our plan. So when you align your vision and your strategy with your money, so your budget and your strategy are together, now you know you have greater strategic alignment and fidelity to that broader vision. And one more thing, government can't do it alone. Government cannot do it alone. And when they do, well, you can see what happens. It doesn't, tip my experience, 30 years in the field, it doesn't bode well. All we have to do is look at the White House and we can see that, right? First example. So we said this has to be not to our community, not consulting with our community, this has to be truly in a more collaborative way. And the journey begun with our community, not ever giving them $1 to doing this, but working now with 425 different organizations who has joined and said, this is what I can do to further childhood obesity, or this is what I could do to further helping disconnected youth to jobs, or this is what I can do for intergenerational, creating safety for kids walking to school. The amazing social movement. So we went from this kind of good initiatives to how do we amass this now social movement, and how do you nurture and feed this social movement that now this kind of hub and spoke model where in the center is not government where we got started, in the center is the deep belief, the social contract that we have an obligation to achieve wellness for all San Diegans. We describe health disparities, not in that way. We describe it of we can only live well when we all live well. And in that, we have now gotten conservative chambers of commerce in parts of the county, in the rural parts of our county, for example. And San Diego, by the way, so you know, is a rural county. I know that's far-fetched, but we are a rural county. We have more farmers and Native American Indian tribes concentrated in any parts of the country. So the rural communities that we had to bring, as well as the inner city, Live Well San Diego has been that inclusive vision of where everyone can see themselves and contributing and have something they can add and influence. And so that one day you've joined us with Cariana, we have what our Live Well Advance, because we advance wellness, we don't retreat. So our Live Well Advance, we bring all our partners and we talk about together, kind of a community huddle, how do we continue to further bring others and support the work that one of us could do, but collectively across sectors we could.
So tell me about how Live Well, but also your organizational approach as an agency. What have you learned from the integration of housing and mental health? And then your indirect relationships. I mean, you have direct relationships, but not procurement relationships with MCOs in the hospitals, maybe some small procurement relationships, but mostly it's indirect. What have you learned about how housing plays into that, both at the direct integration level of your agency, but also with your medical partners?
Yeah, I think it was really, for us, manifested in our efforts of dealing with homeless. So we're the entity with, the mental health services, the healthcare and public health services. And our hospital partners, our Medicaid managed care plans, because many of these were then, deemed eligible for Medicaid, our first responders, public safety again, where health meets safety, because it's a great example. Everyone was equally frustrated. And when you looked at what's happening in terms of what was missing in the years to that was the adequacy of supportive housing in terms of the amount and the type of housing. So, you got to be careful what you ask for, because one of the things we said is, look, this is missing, and they said, well, okay, great. How about we put housing into you? And so 3 years ago, through board ordinance, we integrated housing, which stood alone. And if you ever worked with housing, if anyone's had experience with housing, they have kind of very peculiar nomenclature with HUD, and their funding sources and requirements are very different than most of our CMS or HRSA or Health and Human Service kind of requirements. But that was really important, because what we did, and this is really interesting, what we found, is that our homeless providers and our housing providers knew nothing about Medicaid. Nothing. And so the first order of business was, let's give you Medicaid 101. Let's get you Medicaid certified for those that were beginning to think about serving the whole person wellness. So for us, the awakening happened in several ways. Within the housing community, to talking to landlords. Letting landlords know that Section 8 housing and support housing, that this was about health. This was about their contribution to helping San Diegans, and then bringing the might of our supportive services for behavioral health. We call it full service partnerships, that we do 24/7 care for people in an apartment dwelling or a group home, which for us, we spend about $30,000 a year compared to, with full loaded services, housing, compared to $60,000, $70,000 when they were cycling through the EDs and the jail, excuse me. So that journey opened our eyes to where today we have one of our 1115 Medicaid waivers working with our Medicaid managed care plans. We call it whole person wellness, taking homeless with chronic severe conditions and doing that kind of case management that we've kind of learned of how we've gotten people off the streets, the most severe, severely mentally ill and homeless, off the streets, about 800 so far, and housed and retained in their housing. We are now having our waiver pilot is to look at what about reinvesting the savings, and these are our Medicaid managed care plans who agreed to do this. The savings are back into supportive housing. So it has been critical to our success for the most vulnerable, high-cost need population, particularly the homeless.
So did you say the MCOs are identifying some savings as a result of these programs and reinvesting back into supportive housing?
So in 2010, our first pilot was 33, we called it Project 25, it was supposed to be 25 lives, it was 33 lives. And in a 2-year period, there was a net savings of $3.7 million for 33 lives. Of those 33, today we have about still 21 housed.
Wow.
A few passed away, a few left the program. Medicaid plans have seen that pilot, and that is what led for California of our 1115 waiver. And Governor Newsom, one of the first things he did as governor is to expand that whole person wellness. So we're still too early into, the savings have been pretty modest, to be candid. But I think in year 2, with a few more years, we're going to see adequate savings and that reinvestment.
Yeah. In just a minute, I want to turn over to audience questions if you have them. So Rita, Wade, make sure we have a handheld microphone. Let me ask you, before we get there, I want to ask about Gavin Newsom, and so you can tell us what the future of healthcare policy looks like, because as governor of California, he'll have something to say about that, good, bad, or indifferent. But first, you told a great story last night about this public health disaster that wasn't. That in one of the first epidemic outbreaks in the US in generations that hit San Diego, that really didn't make national news very much, could have, but didn't. You guys averted really disaster. Tell us about the Hep A outbreak and what happened in San Diego there.
So 2 years ago, we detected something quite unusual in our normal surveillance and epidemiology. And that's, by the way, a big shout out to those out here from public health for the work they do and disease surveillance and the importance of having that good data system and the feeding of hospital data to your public health, because we had a lot of painful lessons in San Diego. We did detect an unusual case of hepatitis A. For starters, this is post-vaccine era, and we haven't not quite seen, we would normally have, a couple of cases, maybe 2 cases a month. But this particular strand was not a strand that came, it was a natural strand from us in California. The strand actually was a Middle Eastern strand. So upon seeing that and knowing how quickly that hepatitis A could be, our public health, upon detecting the second case, that now you see a pattern, literally within days, and this is what DJ is talking about, is begun our vaccination campaign. Within the 3rd day, we started vaccinating what we determined to be the population highest at risk. And in rank order, it was the homeless and severely mentally ill homeless, because we saw that this is where people were congregating. This was through, the route was through fecal matter contamination, not food necessarily. And in doing that, we saw that there were the target population of the homeless, the target population of injection drug users because of unsanitary conditions. And then we added also the men who had sex with men population, more precautionary, and then food handlers helping this, and first responders. What's important about that is that the triple aim of public health in preventing and responding to infectious disease agents is vaccination, education, sanitation. And we sprung on to that. Now, I will tell you, it was not an easy journey because we were creating a new playbook that wasn't created. CDC had no guidelines other than vaccination is the way to go. But how to reach, can you imagine a moment if you had an outbreak in Hawaii, for your homeless population, and they had to have a shot by a nurse, and you had to get to them. And if you did not get to them in time, it would risk jumping to the general population. So you had an amount of time. So we had to create this kind of mobile foot teams of our public health nurses, our homeless peers and advocates, building relations. In a matter of literally months, we did end up 9 months, 125,000 vaccinations, predominantly for the target populations. And in the course of that being very vigilant on that focus, we were able to curb and indeed stop the outbreak of hepatitis A, where today we still have 10 states experiencing hepatitis A outbreaks, still fighting hard to curb those. But we looked at it from very an interesting space, because what we learned from that is that we did massive education, washing your hands, the normal universal precautions, but hand washing stations we had to put in, but also inadequacy of restrooms. And for those that have been to San Diego, you probably have seen our homeless population. We're ranked 3rd, 4th in the nation in number of homeless population. There's not enough housing. There's not enough housing for the homeless. So we can't be helpless, we have to be hopeless. It can't be hopeless or helpless, we have to be hopeful for the helpless and for the homeless. So for us now, the rigor about sanitation, working with cities about making sure their streets are clean, because what we've seen some great work Los Angeles done in terms of cleaning their streets and providing services to the homeless on the streets, because in terms of not having enough housing, they have not had outbreaks. Mm-hmm. So again, this is where housing comes in. This is where municipal sanitation and the good old-fashioned rules about good universal sanitation precautions keep things clean and prevent outbreaks.
So just to put a finer point on some of that, it started with a Middle Eastern diaspora in East County, right, a more rural part of the county, jumped to the homeless population, which was mostly urban, I assume.
Mostly urban.
And didn't jump to the rest of the general population.
Right. It did not jump to the men who have sex with men population or the general population.
Yeah, and that you now scrub your streets once a week or once every other week, or like LA does, is that right?
So the cities, it's upon the city's requirements, they do clean their streets. They kept the sanitation ongoing even after we ended the emergency declaration. And the county, so the county has unincorporated land. We have ravines, where people go. we also have stepped up our social contract to keeping those areas clean. But here's the thing. It's not just then sweeping the problem under the rug or shifting them out. It allowed us now to have a much more elevated public policy discussion about how are we going to help this population. Because if it's not Hep A, it's rat lung disease. If it's not that, it's something else. There's going to be always agents that are going to get to where people conjugate with inadequate housing and sanitation.
Yeah.
So we have now stepped up significantly, both the county and the municipalities, on housing.
Yeah, interesting. There's a lot of parallels there with the Hawaii population, particularly with the focus on housing and homelessness. And just I want to get to your questions here in a second. And Rita, she's got a microphone over here. You have, I think, increased to some extent your public restrooms because you don't have enough housing. People still have to do their business, so to speak. And is that accurate? More public restrooms?
Yes. And in fact, during the outbreak, we actually mapped out where all the restrooms were and where we need to expand those restrooms. And so many, if not most, majority of those have maintained to provide that need. And I think that's a minimum. The other part has been, in our point in time count, which is going to be just in about another week, I think we will do nationally, in counting our homeless. Again, the importance of getting our electeds and others and the business community aware of what are the solutions do we need? Mm-hmm. And again, get back to housing. Mm-hmm. Putting people in tents is a temporary solution, providing the kind of services there, but then how do we get them stable? Mm-hmm. And I think we'll always have that challenge in communities that are welcoming, like Hawaii, like San Diego, because it's not just the weather, it's the people. But we have to bring those type of housing solutions then capable of serving them. So we've had some success both with our veterans, with our homeless families, and to a more limited success, but more challenging, is the severely mentally ill homeless.
Mm-hmm. Questions from you all about this experience in San Diego? While people are getting the courage, this isn't a shy bunch, respectful but not shy. We'll let Mohit take this question. I was going to jump in with some other ones, but we'll let him take it.
Mohit Ghosh with Beacon Health Options. Nick, good to see you again. I'm not following you around, honestly. But given the new administration and tremendous focus now on behavioral health, what's your take on having the czar, my nomenclature, but having a very specific behavioral health person in the Newsom administration with the focus that that's going to bring? How do you foresee interacting upstream with the state, and what are you looking for?
Yeah, great question. And we're very fortunate in California. I mean, Governor Brown was a phenomenal governor for California. He had to kind of right ship for us from where we were with our state deficits when he took over 8 years ago. But he had to balance all the needs, right? So he wasn't really a governor focusing too much on health and human services. Governor Newsom is indeed a governor very vested and interested in being the governor of the child and the family. But with that is also the vulnerable adult. So his first release for his budget is very revealing, because he has expanded significantly funding for not only asylum-seeking families, which I think speaks a lot, but what we're going to be doing in California is we already have a Medicaid program for undocumented children, state Medicaid. The governor is proposing now a state Medicaid only program that's going to cover up to 26 years of age. So we will, irrespective of legal status, we will be, I think, one of the first states our size that will provide universal coverage up to 26 years of age. And I think that is his focus, is because in the coverage with our plans is the relationship we're having between what county governments do to severely mentally ill and what the plans are doing in providing from mild to moderate. And the issue is, how do you create that relationship? Because we were ping-ponging quite a bit. And I think we have now begun to look at the entire continuum of care. And that's what San Diego actually has begun looking at in terms of our psychiatric inpatient. From pre-service, point of service, to after service, the entire continuum. To when people present for crisis, when law enforcement gets involved, and getting peers involved and getting people stabilized to avoid coming into the emergency room or the jail, if we can, to what happens when they show up at our county psychiatric hospital or any one of our hospital partners' emergency rooms, and managing that care, and then the step-down care. And so this whole continuum, we have infused, just this year, this past fiscal year, we had $60 million in San Diego, just for our continuum. We have more step-down beds now, I think, than actual inpatient psych beds. I mean, it's remarkable and growing. But having a governor that comes in with the overlay of looking at further supports for whole person care and other resources for the delivery system is going to be important. Our whole big challenge with working with the state, with Governor Newsom, we're excited about, is our Institutes of Mental Disease, the IMD exclusion. And if you're not familiar with that, your jails will know it firsthand. And for any facility that has more than 16 beds, they know that too. Any freestanding psychiatric institution, that is. We can't claim any Medicaid dollars if you exceed 16 beds or you're a jail. So we're working on this IMD exclusion by CMS, and there's some pilot opportunities here. So we have a governor who understands the importance of that. Last one quick thing on this is that what we're seeing, and I'm not sure if you're seeing this in Hawaii, is also the release of what we call the forensic cases. These are severe people who can't stand trial, have committed a serious crime. They're in a state psychiatric hospital. They cannot stay there indefinitely, so they are then, by the court, brought back to their host community jail. They can't stand trial. They languish in the jail for a little while, and then they're released. And we take them in our county psychiatric hospital. So this system is a broken system of the forensic cases. So this is how our community in San Diego, hospitals, FQHCs, mental health outpatient, big shout out to NAMI and Mental Health American, all these entities really coming together to talk about, well, how are we going to manage? How are we not going to further stigmatize, but how do we manage people? And a large part is really, this is the power I think about the social determinants. How the social determinants have come in to really think about how we do that step down in community-based care. And this is something that the governor is really supportive of, so we can stabilize folks. We have a firm belief that we believe we have more people we can get in our clubhouses on the road to recovery from mental illness, that they don't have to be indefinitely institutionalized. And so our big focus is on that rehabilitation and that concept of wellness, even with people with serious mental conditions.
What counsel would you give to this audience of folks who are, as you say, exercising fidelity to their profession or to their organizational approach to improving the healthcare system and the health status of the community here? What counsel would you give them in terms of how to lead those organizations during this time of political, it's sort of a political uncertainty and kind of a moment of some stasis outside of the leadership of Judy Moore Peterson and some others who are driving change here in Hawaii. What counsel do you give the audience here today?
So today we're primarily in a room of just amazing leaders in healthcare, health policy space. And so there's other conferences like this that are human services, and then there's housing. And when you're in those conferences, they're talking about, well, I wish we can connect with the healthcare people and the health people and the managed care organizations. And then when you're with the managed care, they're like, wish we could connect with those human service people so we could do better, social determinants and managed care. And public health has the same. So, in your community here, you have the ability of bringing all those sectors together within the health sector of healthcare, public health, behavioral health, between human services and transportation. I would, also bring in terms of housing, but safety. And if you look around, my challenge would be for even next year's conference. Who's missing that is adding immense value to value-added service to your work, that you're working with in your respective markets or defined areas, but collectively as a community, it matters immensely as you bring these cross sectors. And I haven't talked about the business community yet, or the faith-based community, or the military. I mean, those are other sectors that have to come in. But just in our kind of health and human service family, extended family, that fidelity around population well-being, Again, we don't call it population health because they kind of take that as just more health care, public health. And so that's why we talked about in terms of living well, is how do you bring those other sectors? So it's not really advice. I think you're doing that in Hawaii. It's how do we speed that up? Because we have to really find ways of moving from this kind of collaborative kind of market, co-opetition market we have, to where we can really further integrate to create more of this generative ecosystem. And the general ecosystem is that the MCOs, state public health, local, none of us could do it alone. So you need that inclusive vision. What is that inclusive vision you're going to focus on that can hopefully mobilize everyone coming together towards, and as you do that, then you start focusing on many other things you have to do in your respective organizations. But that meeting of the minds and hearts and souls is so key to our work that we do in San Diego and here in Hawaii.
Nick Macchione, the Director of San Diego County's Health and Human Service Agency, and the Deputy Administrator for San Diego County. Thank you very much, sir, for being with us. I appreciate it. Yeah, always.